Good evening, everyone. I'm Harsha, representing Science Integra, and I extend a warm welcome to all of you for the 23rd episode of the webinar called Maha Smiles Cleft Care for Every Child. So, this event is organized by AMOX in collaboration with Smile Train India and the Public Awareness Committee of FOXY with the aim of raising awareness about cleft lip and palate conditions in children. So it's my pleasure to introduce you all to Miss Renu Mehta ma'am, who is the Area Director of Smile Train in India. Thank you. Over to you, ma'am.
Renu ma'am, can I just request you to please let Amay sir speak today first?
Sure, definitely.
Yes.
Definitely. Dr. Amay, please.
Thank you, Amay sir, for joining us today. This is the third series of the Smile Train webinar, and today is the 23rd episode. Sir is currently the Joint Treasurer of FOXY.
Monica, I think everybody knows you.
Sure, sir. Sure, sir, for your blessings.
Yeah. Welcome everybody for this Maha Smiles webinar. I think we are doing a great job with these webinars. Today is the 23rd episode, and I congratulate Monica and all the organizing team for doing so well and collaborating with such important stakeholders in our mission to prevent and optimize and maximize outcomes in those unfortunate children who do have cleft lip and cleft palate. I think it is the responsibility of every healthcare provider, especially every obstetrician and gynecologist, to counsel the patients about this problem and to support them through this journey. So I'm also happy to see my other colleagues, Dr. Kalyan Barmade, Dr. Manishi Nagaukar, Dr. Madan Kamble, Dr. Parag Biniwale, Dr. Supriya Arwari, Dr. Monica Umbardan, and all those attending as delegates. And I'm sure that all of you will get valuable insights in how to prevent this problem, treat the problem, counsel the patients properly. And I think that will go in a long way in fulfilling our roles and responsibilities as an obstetrician. Special thanks to Renu Mehta ma'am for always collaborating with us, supporting us. Together, we go hand in hand in our fight against preventable cleft lip and cleft palate. So thank you so much. Monica, I am in a bit of an emergency, so I will have to unfortunately take your leave immediately.
Sir, thank you for joining us and praying for sir's speedy recovery. We're all, prayers are always with him, sir.
Thank you.
Yes, sir.
Take care, sir.
Yes, take care.
Thank you, Dr. Amaya.
Thank you.
Monica?
Thank you.
Yeah.
Thank you, ma'am, for allowing sir to speak, and over to you for the introduction, ma'am.
Thank you. Thank you, Dr. Monica. And a warm welcome to everyone. Good evening. As Dr. Monica has already said, that this is the 23rd webinar that we are having, and it is so fortunate for people who are joining us on this webinar that the word is being spread that the vision of Smile Train, which is where every person has access to high quality and that to comprehensive cleft care, is able to get intervention on time, is able to live a full and healthy life. So could we go on to the next slide, please? Yeah, we spoke about our vision and our mission, and I am so thrilled that FOXY has joined hands with Smile Train to take this forward with the entire team in Maharashtra. And this is a specific effort with FOXY and AMOGs that we are taking this up in Maharashtra for past 3 years. Next slide, please. As I already said, that our vision and our mission is to help each and every child that is born with cleft, and it's a comprehensive care. So from diagnosis to counseling, to the orthodontic help, to speech, to psychosocial, to the surgery and beyond, Smile Train is there with the child once the child enters into a Smile Train sponsored or supported partner hospital. Next slide, please. with the help of one of our donors, a few years back, we started our first national and only Cleft helpline, where since January of 19, we have received more than almost 10,000 calls and 6,500 patients have been connected with the Smile Train partner network across the country. So this helpline receives the calls, and we also connect with our patients to get to know whether their surgery or the support could be speech, orthodontics, or nutritional support. Are they happy with the services? What sort of feedback they have? So it is the national helpline, and I urge all our colleagues who have joined us today that please share in your network this helpline number so that more and more children are helped and can reach the nearest Smile Train partner hospital. Next slide, please. Smile Train has been working in India for past 25 years. This is the 25th year. It's a silver jubilee. And we have supported more than 750,000 surgeries so far. We work, as I said, with partner hospitals across the country. And as of today, we have 132 treatment centers where these services are being supported. 57 of these centers are comprehensive care centers where either of one comprehensive aspect is there, be it nutrition, it could be speech, it could be orthodontics. These services are available at our partner network. Next slide, please. So, especially for Maharashtra, we started this effort along with Bajaj, which we termed as Maha Smiles, Cleft Care for Every Child. So, Bajaj FinServ has been supporting Smile Train for a pretty long time. And 3 years back, we decided that let's just pick up one state and make that state cleft free. Now, with cleft free, I would like to say that every child who is born with cleft should be able to reach the nearest facility for timely treatment, and later, if any other intervention is required to that child. So, under the Maha Smiles program, we are going to be helping 8,000 surgeries, and we will be also training and making awareness efforts through the grassroots workers, the ASHA workers, the other health workers in the state, so that this services are availed by each and everyone who's in need. Next slide, please. So in Maharashtra, currently we are supporting 13 treatment centers. And if you see this map, the cities which are underlined are the ones where the treatment centers are there. And we also envisage that we will be increasing our footprints in Maharashtra, and where the gap areas are, we want to have more centers so that patients are not traveling long distances to reach and avail these services. Next slide, please. Yeah, so this is in nutshell what Smile Train is doing with Foxy, with AMOGs, and with Maha Smiles. So with that, I would hand over to Dr. Monica and Dr. Supriya to take this forward. Thank you, everyone.
Thank you, Renu ma'am, for sharing with us what great work Smile Train is doing. I would like to first thank at the instance Dr. Kiran Kurti sir and Bipin sir, who are the AMOG's president and secretary, for allowing us to conduct the Smile Train under the banner of AMOG's. I would also like to thank Dr. Supriya Arwari, my co-convener for the program today. And I would request Supriya ma'am to introduce our guest of honor, Dr. Parag sir and Dr. Kalyan Baramde. Would be introduced by Dr. Madan, who is the MOC of the program. Just to highlight, this is the third series that we will be starting today, and this is the 23rd episode. So we have made a little changes in the program. Immediately after Dr. Chinmay madam talks, we would have a small quiz, the fastest fingers first, for our faculty, which would be posted in the chat box. And we would be discussing the questions after the talk. So that is what we have introduced today as an interactive session. And the highlight would be, we'll be conducting it as a single session webinars, where one speaker from Smile Train would be giving us the entire work outlay that they have been doing. And we will have one speaker from outside so that we finish within the time span they have given us for 1 hour. So request Dr. Supriya Arwari to please introduce our guest of honor, Dr. Parag Beniwale, sir.
Thank you so much, Monica. And at the outset, let me also thank the team captain, Dr. Quinan Kurtakoti and Dr. Bipin Pandit and entire MOX team for allowing us to continue this very, very wonderful webinar series of Smile Train under the aegis of AMOX. And today, as a guest of honor, it's an extreme honor to invite my very, very dear friend, past president of the Pune Society and presently the sitting chairperson of ICOG, Foxy ICOG, Dr. Parag Biniwale. If I keep reading his CV, I think
Thank you, Supriya. Don't read that. Don't
so
waste
over
your
to
time.
Dr. Parag.
Yeah, thank you, Supriya. Good evening. It's indeed a pleasure to be part of today's webinar. And Renuji, excellent presentation. And I very vividly remember in the year 2019 when Dr. Nandita Pashetkar was the president of Foxy. That is the first time we had an online meeting with the Smile Train, and I was part of the meeting. So it's really heartening to see how the work has progressed. And congratulations to you. And I'm sure you will, very soon you will make all the districts really smiling, and there won't be any babies born with the cleft. Uh, Supriya and Monica, I must compliment you for selecting a wonderful speaker. But why I'm saying so is I have known Chinmayi for a very long time, and for me, as a ICOG chairman, she's my ace as far as fetal medicine is concerned. She's very, very sincere course coordinator for the lecture series of ICOG for almost 3.5 years. And wherever there are any problems or whenever there are any hiccups during the program, she's the person to go and then she takes care of everything. So Chinmayi, I'm looking forward to listening to your presentation. I'm sure it's going to be really very, very interesting and a good learning experience for all of us. My best wishes for the program and for the viewers, happy learning. And today, in fact, I'm going to log out a little early because I don't think I'll be able to face the quiz, and that's a big challenge. So let it be the prerogative of all the chairpersons. Thank you very much.
Thank you, Parag, and over
Thank
to
you,
you,
sir.
Monica. Please go carry forward.
Thank you, Parag sir, for joining us and blessing us today. I now request Dr. Madan Kamre to please introduce our guest of honor, Dr. Kalyan Baramde sir, who is the president of IAGE. Madan, are you there? Or I can take the privilege to introduce my mentor in Foxy, Dr. Kalyan Baramde sir.
Yeah, you can, please.
He is currently the president of IAGE, has been the past secretary of the same association. He has been the chairperson of the Infertility Committee of AMOX and the chairperson of the Public Awareness Committee, Foxy, in the past. He is also the executive member of MSR and currently the vice president of IMA Maharashtra State, an active environmentalist and a person to go through to in case of any problems is Dr. Kalyan Baramde. Sir, we welcome you.
Thank you,
And for
ma'am,
your
for
words
such
of
a nice.
wisdom.
Thank you, ma'am, for such a nice words of introduction. Best wishes to 23rd episode of Maha Smile. I'd like to congratulate Dr. Monica and Dr. Supriya, madam, for this initiative. I thank Dr. Renu Mehta, Dr. Chinmayi for taking this project since a long time. And I congratulate the team who is taking this awareness and initiative about cleft lip and cleft palate, the diagnosis, counseling, management of cleft lip, and important is the speech therapy. We are very closely associated with this because we have one center at Latur, Dr. Vittal Lahane, where he has done more than 5,000 surgeries in the past. And that is going to be really helpful for all the obstetricians to make aware about this condition. So many times till today also people come and ask for termination of the pregnancy for cleft lip and cleft palate. Last week only I had one patient. So their counseling about making them aware about the treatment options is very important for such patients. And I like to request Dr. Monica Umbardand to make this helpline available to all gynecologists, that is 1800 103 8301. And please post this in all AMOGs and Foxy groups so that it is going to be helpful for all the patients. If they have any doubts, they can ask the patient. Even there are support groups for such patients, which is going to be helpful. And that will be the real impact of this webinar. I congratulate the team of Maha Smile and all the best for this webinar. Thank you.
Thank you, sir, and wishing
Thank
you
you.
all
Thank
the
you.
very best for all your future endeavors in Foxy.
Thank you, ma'am.
Thank you, sir. Over to you, Madan, sir, for conducting the next session.
Thank you,
Thank you.
Monica.
On my behalf, also, I would like to thank all the guests and the guests of honor, and Dr. Kalyani soon to be our VP. So I would request all our listeners to support him. And Madan Kamble will be going for committee chair for sexual medicine. Very, very hardworking person. So to all our dear listeners, please do support him in the forthcoming elections. Thank you to both of you. Thank you, Monica. And on Monica and my behalf, thank you for allowing us to become committee chairs and helping and serving Foxy. Thank you so much.
Yes, ma'am.
Congratulations to both of you, most deserving people.
Thank,
Thank you. Thank you.
thank you, sir. Thank you so
Yes,
much.
thank you,
Yes.
Supriya,
Over to
ma'am.
Dr. Kamble. Yeah.
Yes, thank you, Supriya, ma'am. And I'm honored to be part of this Maha Smiles and Smile Trim program. I'm happy to invite and introduce for the chairpersons for this session, Dr. Manishi Nagaonkar, sir, who is currently the president of Kolhapur Obstetric and Gynec Society, senior gynecologist at Kolhapur. Next. Yes, I welcome Dr. Veena Tangde, ma'am, who is the president of Mirrors OBGY Society, practicing more than 25 years at Mirrors. Welcome, ma'am. Next. Dr. Poonam Belokar, ma'am, who is the consultant OBGY at Amravati, who is the currently president of Amravati OBGY Society. Welcome, ma'am. Next. Dr. Vaishari Chaudhary, ma'am, welcome, who is the president of Jalgaon Obstetric and Gynae Society. Welcome, ma'am. Next. Yes, I think Yadav sir is not there, who is the president of Latur OBGY Society. Sir is not joined yet. Next, Dr. Meghishree Deshmukh, ma'am, who is the president of Nanded OBGY Society. I think ma'am has not joined yet. I welcome all the chairpersons who have joined for this particular session. And I request Manishi sir to welcome and introduce our speaker, Dr. Chinmay, ma'am. Over to you, Manishi sir.
Madan sir, Bhaurav sir is traveling, so he might not be able to join.
Yeah, he is not picking
Yes,
the
sir.
call.
Yes.
Yeah. Over to you, Manish, sir.
Yeah, thank you, sir, for your kind words. And I really thank Monica madam and Madan Kamble sir, also our president Kiran Kurtakoti and Vipin Pandit sir, for giving me this opportunity. I would like to introduce Chinmay Ratha madam, chairperson Foxy Perinatology Committee 21-24, president SFM Telangana chapter. Is a member of Scientific Committee IMA Telangana, member of AICC RCOG IRC South Zone Committee, director and lead consultant Resolution Center of Fetal Medicine Hyderabad. So long
It's
CV
okay,
is there.
sir.
So
It's
yeah,
absolutely
I
okay.
can kindly request you to start your lecture, madam. Yeah,
Thank you.
thank you.
Thank you so much, sir. And at the outset, I just feel very honored to be part of this webinar because, I mean, not only is the topic extremely, extremely important and very close to my heart, but also being part of any program with AMOGs makes us feel extremely excited because all the participants and all the organizers are so committed to the purpose and just the way the run through for this program happened. So this is a slide that has been prepared on behalf of Foxy, and the Smile Train program is something where Foxy has collaborated with the Smile Train and prepared certain documents and protocols for diagnosis and management of cleft lip and palate. And the people who have been mentioned here on the slides have been part of the Foxy team, which is a core committee to work on this project. So coming to the prenatal diagnosis of cleft lip and palate, it comes in the category of craniofacial anomalies. And these can result from deformities in the growth of the head and facial bones and have significant functional and cosmetic consequences. Now, they are actually correctable abnormalities as long as they can be triaged by proper prenatal diagnosis for a serial follow-up and postnatal correction. So the correction is always postnatal. Prenatal diagnosis only alerts us that there will be a need for postnatal correction. And this is all possible if we can make a cohesive multidisciplinary team, which will help in optimizing the final outcome. So when we do prenatal diagnosis, we use the protocol given by the International Society for Ultrasound in Obstetrics and Gynecology, and it defines 3 planes to look at the fetal face: the coronal view of the upper lip, nose, and nostrils, the orbits with the lenses, and the median facial profile. So when we do this, these views are sufficient for diagnosing prenatally the cleft of the lip and the palate. So for people who are not used to seeing pictures of the ultrasound carefully at this time, I will just run through some schematic diagrams which will help you understand that when we investigate the fetal face during the anomaly scan, we look through several planes. So the picture there on the face and those red lines that have been drawn are demarcating the planes at which we investigate the fetal face. So if you see there is a plane across the orbits, there is a plane across the maxilla, and there is a plane across the mandible. Whenever there is a cleft of the palate, we are expecting a cleft at the level of the maxilla. The maxilla, or the hard palate, the bone which is just behind the upper lip, is the one which gets affected. So you can see here that if you get a normal picture of the maxilla and a normal picture of the profile, as we will see further, that is extremely reassuring. And you can see the lips and the nose in the coronal view. So again, the arrow here or the line here shows that you have put your transducer in a way that you can see the coronal picture of the face. And if you can see the coronal picture, you can see the lips, the nostrils, and the entire apparatus here in that much clarity, so that if there is a cleft, it has to be detected. Now, at the risk of sounding a little severe, I will say that missing cleft lip palate will actually be considered negligence, because this should be seen as part of a normal anomaly scan, a routine anomaly scan that we are supposed to do in the mid-trimester for every pregnant woman. The views are very well defined, and these are the videos where you can see that just by just a panoramic view of the face, defined planes, axial planes, coronal planes, and sagittal planes, we should be able to rule out cleft lip and palate, at least the hard palate, in a routine antenatal ultrasound. If sometimes it's difficult to see the face because there is very little liquor or the baby is not actually showing up, that has to be documented. But if you have seen the face, there is no way you will miss this anomaly if you see it properly, because like you are seeing in these pictures, the definition is extremely clear. Now, the prevalence of facial clefts is about 0.15%. And antenatal ultrasonography is an accurate and reliable tool to detect these malformations, and hence I'm speaking about prenatal diagnosis. Many times these are isolated problems, but in some cases they may be part of genetic syndromes or other conditions that are happening in the baby, and therefore it is important to look for other abnormalities at the same time. But since we are dealing with this concept as a isolated cleft lip and palate, my talk today will be limited to the diagnosis of cleft lip and palate. So Cleft is something where there is a breach in the continuity of the facial contours. And as you can see here, you may have a unilateral cleft lip, you may have a unilateral cleft lip and palate, and you may have a bilateral cleft lip and palate. And all these result from different levels of embryological disruption in the formation of the structure. And whatever you can see as pictures that you recognize very well, which are postnatal pictures, you can actually see them in that much clarity in the antenatal scans. And if you look at those pictures carefully, you will be able to make out the clefts at the points which have been demarcated with the red arrows there. So you see that the palate is interrupted in the first picture at two places, which indicates bilateral cleft palate. Here on one side, you have an interruption of the lip that you can see in the coronal view. And if you go to the axial view, you see that it is extending even up to the palate. So that is a cleft lip and palate. So again, these are pictures. I'm putting a lot of ultrasound pictures and videos just to run this past all obstetricians that it is not rocket science and it is not something very difficult to detect. And therefore, as much as possible, we should have had an established prenatal diagnosis in cleft lip and palate. I agree that we will not be able to treat it intrauterine. We will not be able to do anything much more intrauterine, but the awareness that there is an abnormality in the face in the intrauterine period helps to prepare the team for postnatal correction, helps to prepare the parents mentally that this is how the child is going to be born, this is how it's going to look at the time of birth, but eventually there will be correction required and it can be done. Also, in some rare cases, if there is a need for looking for any genetic or chromosomal abnormalities as associations, that can be done at that point. So it's a correctable abnormality requiring a lot of detailed counseling and support. So again, I would bring your attention to these pictures, which are extremely, extremely clear. And when you see a normal picture, which is depicted by the white arrow here, you see a completely intact lip, upper lip there. Whereas on the blue arrow, you're able to see a defect in the lip. Here we use what we call as volume imaging or surface rendering to recreate that picture for the patient. So if you see on my grayscale image, I have been able to see that there is a interruption in the upper lip, and therefore I have diagnosed what is called a cleft lip. But when I say cleft lip, I can talk to my peers and they will understand. But when you talk to the patient, they don't necessarily understand what exactly you're trying to say. So sometimes we show them pictures directly from the internet because they're so easily available and something that they can understand very clearly. But otherwise, what we do is we recreate that picture by a three-dimensional rendering of the fetal face. So as you can see here, this is the fetal face. Everything, the surface rendering is covered like normal anatomy. But when you look at the upper lip, there is a distinct cleft in the upper lip, and it shows that this is the extent of the problem. Now, because this is just an isolated cleft lip, the problem actually is easily correctable. So if you go on describing some facial abnormality, the patient starts panicking a lot. But when you show them that this is exactly the problem that there is, then they understand that the limit of the problem is small and it can be corrected, and their confidence in continuing the pregnancy and hoping for a postnatal correction improves a lot. Isolated cleft lip has extremely good prognosis because the only problem is the interruption of the lip and more or less a cosmetic issue. So after birth, sometimes you can expect a completely normal outcome just by minor corrective surgery of the lip, because the internal apparatus of the bony palate, the hearing mechanisms, the speech mechanisms, most of the things are not affected. So isolated cleft lip has a very good prognosis. Now, whenever you get a referral for cleft lip and palate, it is important for you to segregate whether it is an isolated cleft lip or a cleft lip and palate. So this is one of those videos where the way we segregate, I'm trying to explain to you. So you can see the moving video where you see that the baby is swallowing, moving. So you're seeing all apparatus of the baby's face. And you can make out that while the profile is looking very, very normal here in the sense that the maxilla has a very rectangular appearance, but when you look at the coronal view, you can see the little indentation and a little defect in the upper lip. But there is no defect in the bony level. The baby is swallowing well, and you are able to see a rectangular palate here. So you have excluded a cleft palate and made a diagnosis very confidently of just an isolated cleft lip. And like I told you, this is one condition which does not require that much intensive postnatal follow-up, and the outcomes are going to be very good. So she can be delivered anywhere she wants. She can be taken care of postnatally, and then the baby can be brought for postnatal surgery. So again, 3D rendering helps here because it just brings things into perspective and lets the parents relax that the problem is not so severe, and they can see it here and they feel better when they see an isolated cleft lip. The incidence of a unilateral cleft lip is about 29% among all the clefts. The unilateral cleft lip and palate is about 40%, bilateral cleft lip and palate about 27%, and bilateral cleft lip is about 5%. So all of them will be difficult to delineate unless you follow a good protocol and make it a point to see the coronal view of the lip for the cleft lip and the axial view of the palate for the cleft palate. So this is how cleft palate looks different from the regular cleft lip, that you see an interruption in the axial view of the palate. Normally you see a continuous C-like structure of the maxilla, which is the usual thing that you see. But when there is a cleft, you can see a complete interruption there. You can see a distance between the bony margins. And again, when you do a surface rendering, this looks a little more severe than what you saw as an isolated cleft lip. You see the gap going right inside and affecting the oral cavity in a very, very significant way. So this is a cleft lip and palate. Now, it is sometimes tricky because you have a shadow there. So when you have to look at the bony palate, it is not so difficult. But when you want to look at the soft palate behind the bony palate, that is sometimes difficult to confirm on ultrasound, because there is always a shadow of the bone that impedes the imaging of the soft palate. And therefore, sometimes it may be possible that you may have missed a soft palate cleft. But if you scan properly, a hard palate cleft should not be missed. The way the palate develops is that there are 5 distinct regions of the palate. And when we are talking about cleft lip and palate in terms of the smile train concept here, we are actually looking at the bony palate, and that is the imaging that I am concentrating on. So the maxilla with its alveolar ridges, the upper lip and the lower lip in the coronal view, these are the views which we recommend that every obstetrician should insist that the person who has done the anomaly scan should give these images as part of the anomaly report, so that you are sure that you are not going to deal with it. Now, it's not a life-threatening situation, but the problem is if you have a anomaly in the face which was not anticipated, leads to a lot of distress after birth, and being prepared is something that is better than something coming as a rude shock at the time of birth. So the profile pictures are again part of the normal views of mid-trimester anomaly scan. And whenever there are clefts, the rectangular margin of the maxilla gets disturbed and you start seeing gaps there. So the technical limitations of missing a cleft are definitely known. And although I started saying that it has to be something which is detectable, there may be artifacts, there may be reasons why you would misinterpret your images. So this is not an excuse for us to say that we can miss cleft lip and palate, but these are the reasons why things may not be ideal. So a person who does regular scanning should ensure that these artifacts are properly handled, and neither you miss a cleft lip palate nor you misdiagnose a cleft lip palate. For example, when we do a 3D rendering, suppose there is a shadow of a hand or a umbilical cord which is right across the baby's face, sometimes you may falsely diagnose a cleft which does not actually exist. And similarly, if there is a bony shadow somewhere falling on the palate, you may falsely diagnose a cleft palate. So it is important that you look at the fetal scan in the spirit of the scan, move with the baby, make sure that the particular areas that you are scanning are free from unnecessary shadows, and therefore make an accurate diagnosis of either the presence or the absence. Because sometimes you can even do that. We all many times get referrals for cleft lip and palate, which is not actually cleft lip and palate. So it may be sometimes misinterpreted the other way also. So just like missing the cleft is a problem, over-diagnosing misdiagnosing the cleft is also a problem. So it is important that we get used to the pictures. For example, here, if you see this maxilla looks a little interrupted there, but that is just a positional interruption. It is not a true interruption. And if you reposition the frame, you will see that that is not the true cleft. It is just an artifact which looks like a cleft. So identifying the cleft on the scan is not impossible, and it has to be done whenever you do the 20+2 plane approach of a SWOG. The information that the plastic surgeon wants from us, although that person will not be operating in utero, but when we send them for counseling to the multidisciplinary team, they want to know if there are any other abnormalities in the face at that point in time, and also how much is the defect. If the defect is very small, then the positioning these ends after the birth for the corrective surgery is easy. But whereas if it is a large defect, then the correction will require a multi-pronged approach, and the effect on the speech and hearing of the baby would also be more pronounced. So it is important that we start looking at it. And similarly, we also look at the equal to sign in the pharynx of the fetus during the evaluation of cleft lip and palate, which tells us that the soft palate is present or absent. So the equal to sign, as you can see here, is a little structure that is seen in the pharynx. When there is fluid in the pharynx, you can see something dangling there, which is a representative of the uvula, and that tells us that the soft palate is intact. All this I have mentioned in the second trimester scan, which is the most realistic time when you can detect cleft lip and palate. But today everything has become faster, and things have become more efficient, and we have started detecting more stuff on the first trimester scan, and therefore it is prudent to imagine that we can also look for a cleft lip and palate in the first trimester scan. If you are in confusion and you are not sure in the first trimester, most of us advise that wait till the second trimester and confirm it. However, if it is very obvious and you are really able to make that diagnosis, do reveal it in the first trimester. So in the first trimester, we look at the fetal phase in the sagittal section all the time, because we are doing the nuchal translucency assessment. In nuchal translucency, the way we define the maxilla is a rectangular structure, and when you look at it very carefully, you can see the vomer bone also there, and you can see what is called the superimposed sign of the presence of the vomer and the continuous structure, which represents an intact maxilla. However, if there is an abnormality, you will see an interruption in that view. Similarly, on the coronal view, we don't look at the lips in this condition, but we look at the bones underneath the nasal bones, which is known as the retronasal triangle or the premaxillary triangle. And you see that the apex of this triangle is formed by both the nasal bones, and the base is actually the maxilla. So suppose that is interrupted, again, you will suspect a cleft lip and palate. So an intact maxilla is a very reassuring sign in the first trimester, whereas if there is a gap in that maxilla, you suspect a cleft palate in the first trimester. Again, a word of caution: if you are very sure, very experienced, then do report it in the first trimester. If you are not sure, it is better we wait till 16 weeks and reconfirm it before we break the news to the parents, because it leads to a lot of unnecessary chaos and confusion. So in the first trimester, you look at the sagittal section, the axillary section, and also the coronal section. Dr. Lakshmi Ravi is one of our scientists, obstetricians in India, from Krishnagiri in Karnataka, and she has actually defined the maxillary gap sign very well, and it has been internationally acclaimed, and therefore I am acknowledging her work in the first trimester diagnosis of palatine clefts. Now, this is the FOGSI recommendation that the planes that we should be looking for evaluating the lip and palate in a fetus in the first trimester should be the sagittal, axial, and coronal, which we just saw, the sagittal, axial, and coronal. And in the second trimester also, the sagittal, axial, and coronal. So all three views, all three planes must be evaluated in both the first and the second trimester for a comprehensive diagnosis of cleft lip and palate. This is again what I have just explained to you in detail, and just a revision that whenever you are doing a second trimester scan, a coronal view will help you show the integrity of the upper lip, and that should be done without fail to not miss a cleft lip, and an axial view with a proper continuity of the alveolar ridge will help us rule out a cleft palate. A sagittal view is always good because the profile gets significantly distorted whenever there is a major cleft. So all these three views, if they are normal, you can confidently tell the parents that at least there is no hard palate cleft or a lip cleft. So whenever there is a diagnosis of cleft lip and palate, that making the diagnosis is very easy actually, but thereafter you have to think of a multidisciplinary team which will take care of this condition after birth. So as I said, it is a correctable abnormality, but it definitely requires surgery. Patients will often ask that, when the pregnancy continues, do you think it is going to close on its own? Do you think the gap will spontaneously close? It does not close spontaneously. It has to be closed by surgery. Even an isolated cleft lip needs surgery. Hence, it is good to direct them to the surgical team in the antenatal period so that they have a continuity of care thereon. The neonatologist needs to be involved because when there is a cleft of the lip also, there may be difficulty in sucking. And if there is a cleft of the palate, there will be definitely difficulty in sucking. So the baby has to receive special type of support to occlude the palate at the time of breastfeeding or neonatal feeding at that point. Special feeders are available, and this needs to be told to them. While we are talking about all this in a technical way, for the parents, this is a huge emotional trauma, and therefore psychological support and counseling must be available for these parents to accept the situation, because it's very difficult for a family to look at a baby. As soon as the baby is born, one looks at the face, and if the face is distorted, it is a cause of great emotional distress. So that has to be explained to them sympathetically, and sometimes it's good to inform them and put them across other parents who've had similar experience so that they can get what is called a support group advantage. So detailed explanation of the problem, potential to correct, and only if there are a lot of other abnormalities, we suggest a genetic workup with amniocentesis and microarray. But isolated cleft lip palate generally is not associated with problems, so it's not like a mandatory thing to do genetic workup. But suppose the parents are keen and they want to rule out anything that is that could be an associated problem, then you can offer genetic testing. Pediatric plastic surgeon counseling has to be done. So the same Smile Train program runs in Telangana in Nizam Institute of Medical Sciences, and I would like to acknowledge here the work done by Professor Parvati, who is the head of plastic surgery in NIMS, and she's such a wonderful doctor that despite being in the government sector, she offers to give her cell phone number and her contact details to the patient, so the patients can go and contact her there in NIMS. The surgery is done free of cost. The government takes that cost, and they are even giving them about a transport allowance of 1,000 rupees. So the same Smile Train program runs very successfully in Telangana and has helped to save a lot of our babies with cleft lip and palate, because the fear of the unknown, the fear of the cost of the treatment, the fear of availability of the treatment is often the reason why patients terminate such conditions. Whereas since it is correctable, we send them there, and this is how they show them the videos of children who have had corrections in the past, and show them that how the outcome can be so good and the babies can look so beautiful after the surgery, and then that encourages the parents to continue. So a multidisciplinary approach with a cohesive interdisciplinary communication helps in improving the outcomes of cleft lip and palate. So it's always a teamwork. The surgery is not done immediately. It's done only after 3 to 6 months of age. And there is a general consensus that palatoplasty should be done after 6 to 12 months. So this is again the Foxy slide, which says the timelines of cleft lip care. So immediately after birth, you check for the airway maintenance and all the associated anomalies. And then 3 to 6 months later, you plan for the lip surgery. If a palate surgery has to be done, they have given a timeline of 9 to 18 months also, because the more the baby, when a newborn baby is handled by the surgical team, they are looking at everything, including the possibility of inserting sutures in that fragile skin. So it's always prudent to wait for some time, let the baby mature, let the skin mature, and then the surgery can be planned thereafter. Nutrition can be taken care by the multidisciplinary team, and the speech therapy and hearing. Now things have become so well coordinated, and these things have advanced to limits beyond what we can think of, that there are surgeons who just work on clefts, and they have improved the entire team so well that the outcomes are excellent. I actually remember that about 2-3 years back in Belgaum, they had the Indo Cleft Con. The whole conference was only on the cleft lip palate, and I was asked to speak on prenatal diagnosis there. And it was so wonderful to see that in their inauguration, the entire inaugural program was conducted by children who had been repaired after cleft. So even the inaugural song was sung by children who had cleft lip corrective surgery. So to that extent, they are able to improve the speech and hearing abilities of these children, that they can actually produce beautiful, soulful music. So this up to adolescence, there may be a continuous need for revision of surgery and different stages of surgery. But the fact that all this is available and programs like Smile Train make it very affordable for the patients, and therefore there is no need to panic with the diagnosis of cleft lip or palate. So psychological preparation, parent education, planned care and feeding, looking at what all genetic conditions they require, and then giving them the options to continue. Extreme anxiety can be sometimes generated the way we describe the problem, and then parents may want to have a termination. I can't say that all my patients with cleft lip and palate have continued. Many actually get a little disturbed. Then there is a lot of input that comes from social sources, parents, neighbors, all kinds of people are counseling them, and that's just the sad part. So our role as healthcare providers is to improve their awareness levels, is to give them correct facts and figures, give them what to expect, and offer them a clear protocol for postnatal management. So in the immediate newborn period, one has to be careful that airway management and feeding is very important. So, even if we have seen only one abnormality in the antenatal period, it's a useful thing to do a proper newborn assessment and see that there are no other problems, and tell the mother that, so in our unit, what we tell them is to put a mask across the baby's face, so that as soon as somebody sees the baby, that's not the first thing that comes to their mind, because 3 to 6 months they have to wait for the surgery. So it's a good idea to just wear a mask like a normal thing and not expose the baby to unnecessary comments by other people. So these are some of our babies who have had surgical repair, and they look so beautiful and so nice, and the parents have been kind enough to share the pictures with us. So these babies help in saving other babies, because when we tell them the journey of these babies through in fetal period to newborn and then adolescence, the other parents get inspired. So I think each of us should have, just like Dr. Kalyan was saying, that he has a center where so many cleft surgeries are being done. So when you show them local outcomes, when you show them the success stories of your own patients, the uptake of the process of treatment becomes much better. So the answer to a crisis in pregnancy is to eliminate the crisis and not the pregnancy itself. So we should not be rushing towards termination when there is a diagnosis of cleft lip and palate. And that is why any anomaly scan should not be done as a PR exercise. Whenever you start doing a scan, first ensure that you've seen everything and then get the rest of the family inside. Otherwise, people start doing it like a show, and then it's very difficult to counsel when there is a problem. So antenatal counseling always includes prognosticating an issue, planning antenatal care, planning delivery, and the newborn care. And whenever needed, revisit the issue and counsel the patients again. This is a question every parent will ask you. Can you give us a guarantee that everything will be fine? Because you will explain the whole process and they say, so can you give us a guarantee everything is fine? So the answer to all that is always that we will work as a team. We cannot guarantee that we will be able to cure everything, but we can definitely guarantee that we will care for everything. So as a perinatal team, there is definitely a guarantee for care, and programs like the Smile Train give us that opportunity to provide that care through and through life course for those babies. So thank you very much for a very patient hearing. And if there are any questions, I'd be happy to answer.
Thank you. Thank you, ma'am. I would request our chairpersons, Dr. Veena madam, Vaishali ma'am, Poonam ma'am, to please give their expert comments so that then we can take the questions from the audience. Ma'am, you need to unmute. Veena ma'am.
Hello,
Yes, ma'am.
can you hear me? Hello.
Yes, ma'am.
It was a wonderful lecture from Chinmay Ratha madam. It was really very informative. She talked regarding the first trimester, the second trimester, and those sagittal views, axial views. Are really very informative lecture from Madam Chinmay Ratha. Very nice, madam. Thank you, ma'am.
Thank you so much, ma'am.
Vaishali ma'am.
Yes, madam, it was really very informative, right from diagnosis to the counseling, because counseling part is more important. One of my patient was very sad when she had found out her baby like that. I have counseled her relatives and everything. They were ready to accept it, but she was not ready to accept it initially. And after 2 years, she came that baby after operation, and she was very happy.
Exactly, madam. I think it's the fear of the unknown why they get very scared. So if we explain to them and show them pictures of other babies who've had surgery, they feel better. So that's very nice. Your experience is like something which will help other patients.
Yes, madam. Thank you.
Very nice presentation, Ratha madam. Congratulations.
Thank you.
Very nice, madam. Very well explained, and each and every point is very clear. Congratulations, ma'am.
Thank you. Thank you so much.
Madan sir, I have posted the questions to you so that you can take the questions later. But I was also very happy, ma'am, that Lahane sir was very much a part of our series in the last series 2, the last one which we done. And sir had presented very beautifully his journey, how he started from a single room clinic to what he has been doing in Smile Train over these years. And we also requested that in case if somebody wants to contribute to Smile Train, then also it would be a lot of help to the NGO and the mothers to give them free surgery. If possible, if anybody is interested, please do let us know. We will be posting the link in our group so that we can help Smile Train with the same, ma'am.
Yes, it was a fantastic presentation, Chinmay ma'am. Thank you for the same. There are some few questions from audience. First question is, what would you recommend to sonographers and fellow OBGYNs to improve early detection and referral?
So, sir, definitely now sonography has become very structured and there is a lot of training avenues available. So, definitely the face has to be evaluated with a little more detailing than just a cursory look. So, in the first trimester, when we do the NT view, just look at that palate, the rectangular palate, the intactness of the superimposed line and the maxilla itself is a indicator that things are good. In the second trimester, there is no excuse not to see the coronal view of the lips and the nose because it's a very simple view. Now, I cannot explain how to get that view just by talking to you because everything has to be done and practiced. But after you learn it, it's like cycling. How will you explain somebody how to cycle on the thing? So once you start cycling, you know that you won't go wrong and there is a method one after the other. So we do regular trainings for candidates who come for learning scans. And I don't see a lot of difficulty in gaining this skill. Maybe a few days practice and then they can gain it. So anybody who is taking responsibility for fetal scans, strongly recommend to follow a protocol and definitely acquire the skill to get these views. For the obstetricians, please insist on these pictures. See, the anomaly scan report cannot be a half-page report with 2 pictures. It has to be a 20-picture series of documentation that all these parts have been seen because you are doing obstetric care for that baby without knowing what has been seen. So as obstetricians, please insist that give us a minimum of 24 to 30 because that 20 planes have to be documented on the paper. And you once you see that the lip is intact, then that's very, very reassuring.
Thank you, ma'am. One more question is there. Do you recommend genetics testing for all prenatally diagnosed clefts, and in which cases?
Yes, sir. So, like I said, once we notice one abnormality, then the rule is to go and look at the baby again and make sure that there is no other abnormality. So, suppose we are seeing 2 or 3 different things. For example, there is a VSD, there is a cleft lip and palate, there is also some kind of, maybe a short limbs or anything. Then we will suspect it may be part of a chromosomal or genetic syndrome. And in that case, we will go for particular testing. But if it is otherwise isolated, then we don't insist on the testing. Whether we recommend or not, yes, we recommend, because any abnormality, especially, and I am a little biased on that point because I deal with only abnormal fetuses 90% of the time. So the association with genetic conditions is not unknown. And if parents want, then they can at least do a microarray, if not a complete exome sequencing. So we do offer them, but we don't insist when it is just an isolated cleft lip and palate with a normally growing baby. We don't insist. But if there are multiple abnormalities, then definitely yes.
Thank you so much.
Thank
Monica?
Thank you, Chinmay ma'am, for an exhaustive talk, and I am sure all our attendees as well as our esteemed faculty members will be able to answer the quiz that has been posted in the chat box by Harsha. Thank you, Harsha, for all the technical help, and thank you, Renu Madam and Chavi, for this academic platform, which has been jointly hosted by AMOGS and SmileTrain. I would also like to extend my heartfelt thanks to Dr. Amay Purandre for joining us in spite of family issues, and Dr. Parag Beniwale sir and Kalyan sir for joining us as the guest of honor. Our chairpersons, Dr. Manishi sir, Dr. Veena madam, Dr. Vaishali Chaudhary madam, Dr. Poonam Devlikar ma'am. Bhaurav sir could not join because he is traveling. So thank you everyone, and Chinmay ma'am, a heartfelt thanks to you, because whenever we have called you, you have never said no for any academic session, ma'am. So thank you so much, ma'am.
Thank you, Monica. And I think no, the sincerity with which you work in the field of education, I don't feel that one should say no, because, and the excitement that you generate and the sincerity with which the entire AMOGS team listens to the program makes it all worthwhile. So my thanks to all of you for this kind invitation. Thank you.
Thank you, ma'am. Thank you. Thank you, Dr. Madan and Dr. Supriya.
Sorry to
Yes,
interrupt
madam.
you all.
Thank you.
Yeah. So I just wanted to say that we can do a live quiz. So everyone can join the link I have shared in chat room. So we'll start the quiz after everyone's joined, and we'll continue this. So I'll just do a screen share so that you can see the code that you have to enter. Is everyone? Yeah. Everyone has to join the link.
Yeah, you can use the code which is seen on the link to join the online quiz.
Yes. It's 4425303. 2 participants has joined, Charvi and Manishi. I request you to join everyone so that we can continue with the quiz.
I am not able to join in, Harsha, because my phone is showing not logged in right present in Google. So just taking time.
Okay.
Request everyone else to please join the quiz. It would hardly take around 5 to 10 seconds for the questions. These are all MCQ questions.
Yes, it's 5 questions only. Is everybody able to click the links? Or shall I share on WhatsApp group as well, the quiz link? Yeah, Dr. Vishali has joined now.
I think, Harsha, we can start the quiz now.
Okay, there are three participants only. So can I start the quiz, ma'am?
Yeah, start the quiz.
Okay.
And you can post that in the delegate links also, because this is only the faculty link, right?
Yeah.
Hello, Harsha ma'am. हे 3 जॉईन झालंय लिंक इथे पाठवते म्हणजे नाहीच पाठवलं. हॅलो हर्षा मॅम.
Hello. Yes,
Hello,
ma'am.
Harsha ma'am. How to join?
You just have to click the link which I have sent on
There is a link in the chat box, ma'am. You can join from the link.
Zoom chat, and you have to apply that code 42530003.
नंबर है मेरा कॅपिटल आला ना सगळं. डॉट कुठे आहे Okay.
Hello. Please do let me know when you are over with the quiz so that I can end for all.